Hey everyone, it's Dave. So I wanted to put together a video for you that accomplishes, I think, a couple things. One is a little more uh, information about the American Psychiatric Association, and that's actually the link that you see here. You could just use psychiatry.org, and that will lead you to this site. So I'm going to walk you through the site a little bit. But I also want to have some discussion in this video regarding the different ways that clinicians, for example, help to assess if someone has symptoms of schizophrenia. So I have two different tools that I'm going to share with you, but I thought we would first begin with a little exploration of psychiatry.org. So again, this is the American Psychiatric Association, their site one of the main site that you're looking at. You can navigate this in different ways, but I would encourage you to click on patients and families like I've done here, and it will bring you to this really treasure trove of information. What I want to point you to, though, is right here, find a psychiatrist. If you or a family member or someone else that you know might be looking for a psychiatrist, all that you need to do is click on that link and type in zip code, and then let the search engine know within what radius you want to be looking. For example, I typed in 20 miles, and from the Fall River Taunton area, it came up with about 9 different psychiatrists. So again, it's a resource if that's something that you or someone you know might need. But I think most importantly is when you really move through the different links here, it gives you really a lot of great information. I think we've already spent some time talking about some of the warning signs of mental illness, but I point you, for example, to if you wanted to learn more about electroconvulsive therapy, for example, if you wanted to learn more about addictions to technology, social media, online gaming, etc., you'd find that here. So I think a lot of outside of the course content that I've shared with you so far in Canvas, I think that this is, as I said, another resource. But let's really get to, I think, the more pertinent part for us today, which would be this link, schizophrenia. So as you know, we spend an entire chapter talking about schizophrenia, but I always want to provide you with other opportunities for learning, and this happens to be one of them. So again, it does provide, I think, some core information. It says, for example, that it is a chronic brain disorder. I've also referred to it as a thought disorder in the lecture videos, for example, that I created for you. You could move through this. You see there's a Q&A here, and there are more. There's some FAQs there as well. So again, really good information, but let's go a little deeper. So again, the diagnosis of schizophrenia and other related thought disorders and or psychotic disorders are discussed here. So let's get into some main definitions, and by that I mean some main criteria. So again, psychosis is the common theme among all of the different disorders that we discuss in chapter 13. Delusions as well, hallucinations, disorganized thinking and speech, and also disorganized or abnormal motor behavior. And because this is a thought disorder, it is a chronic brain illness. That's why you see these different criteria, if you will, that are related to brain function. So, for example, if someone's thoughts are very, very disorganized, which is one of the common themes of schizophrenia, for example, well, you would think then that their speech is going to be very disorganized too, and that does occur. Not in all people, though, with a diagnosis of schizophrenia. Also, their behavior might be very disorganized, or their movements might also appear to be very different or bizarre as compared to other people in a similar environment, for example. So again, you can go look at this more, but these are really the core, I think, criteria of schizophrenia, and then it gets into more discussion here, which I did in the lecture videos. I really wanted you to understand the difference between positive and negative symptoms. They're discussed here again. Again, the way that I think about positive symptoms, for example, it's the addition of something that is typically not there. So, for example, for most people, hallucinations are not present. And it's a positive symptom in regards to schizophrenia because it is an addition to something that we typically don't see. So it's, again, an addition to typical behaviors. And then if you look at negative symptoms, and negative in this case not necessarily meaning bad, but think of the absence of. So, for example, most people have a relatively wide range of facial expressions, for example. I won't demonstrate the majority of them, but there's one right there. And in schizophrenia, people may actually lack a range of facial expressions. The emotion that is behind the facial expressions are lessened. So the impairment in this case is emotional expression, and you'll hear it's a fancier term, but it's affective flattening, or even more common would be flat affect. So if you hear someone in terms of their behavior being described by someone else, if you hear the term flat affect, it generally means really lacking in facial expression and lacking in emotional affect or expression. Also, reduced desire to have social contact with people. This is not the same as antisocial behavior. We'll call this asocial. So asocial, again, meaning just the lack of desire to engage with other people. I'll tell you a very quick story. Someone that I worked with for a long time with the Department of Mental Health. She was a social worker, and she had worked, for example, in Boston and with the homeless. And one thing that she learned from working in this unit that was a community-based unit that went out into the community to try to engage with people with severe mental illness who were homeless. One thing that she observed is she could tell the difference between sometimes folks who were homeless and probably had a severe mental illness like schizophrenia versus maybe an addiction. So what she observed was it was more common for people with schizophrenia to want to isolate. They were usually by themselves and would be less likely to want to engage with other people, where people that may have, for example, been struggling with addiction, it would be more common for them to congregate together. Very interesting. And then, again, just these disorganized symptoms in general, disorganized thinking, disorganized speech. I think I've used the word or the phrase word salad before. That's a more common term, and it really is if you listened or heard someone speaking using this very disorganized speech, this word salad, it has a cling-clang aspect to it sometimes. It is just a very bizarre collection of words that usually don't make any sense, but it's also a signal of really how disorganized that person's thoughts are. So again, think in terms of cognition, think in terms of brain function. I've already discussed here in chapter 13 the prevalence, I should say not the prevalence, but the likelihood of when the symptoms will first start to appear. What I really wanted to draw your attention to here is a little more discussion about some treatment. I think it's really interesting, their discussion here about the role of family support, for example, other resources. So again, take a look at this when you can. And then even better, there are some other illnesses here that are in chapter 13 that I talked about, but I think if you have the time, I would suggest that you spend a few minutes checking these out as well. As I've said before, just another opportunity for learning. So what I want to shift to now is looking at some tools that clinicians, for example, therapists, psychiatrists, social workers, psychiatrists might use, nurse practitioners might use to help to determine if someone meets some of these criteria, some of these, quote, definitions that I showed you here on this site. So I'm going to switch to that now. So this is just one. It's called the Brief Psychiatric Rating Scale. It's been around for a little while. The difference with this is compared to some others. This would actually be filled out by the clinician. So they are basing this, their assessment, if you will, using this rating tool, this rating scale, based on their observations of that person when they're meeting with them, or hopefully in more than one meeting, perhaps. But they could also could possibly use some information from, say, family members or other people that know the person. So as you see here, it's broken down into a number of different buckets or categories. But when you think about these are all additional, or I should say, related criteria or symptoms for schizophrenia. Let's look at one, blunted affect. And that's another term that you'll hear, but it's the same thing as flat affect, for example. Again, a reduction of the presence of emotional tone, lack of normal feelings or things of that nature. Grandiosity can also be present, and again, thinking in terms of delusions. Folks that are delusional have a lack of contact or a loss of contact with reality, and their grandiosity might be in terms of their beliefs about themselves. That's where you'll have some folks who, if they are very delusional, therefore very grandiose, they might describe themselves to you as being Jesus Christ or Napoleon Bonaparte or President Obama, etc. And of course, that is not based in reality at all, but it is in their minds, and it's very real for them. You could also have some suspiciousness, and that, as we've discussed this previously, paranoid type was a kind of a subsection of schizophrenia. So there was a way to designate if folks had schizophrenia, but also were showing very paranoid symptoms. They would have this qualifier called paranoid type. And that's really begun to really change in the DSM-5 and the DSM-TR, the text revision, that's now out. But my point in saying that is you could have some folks who have schizophrenia, or at least are demonstrating some of the symptoms of it, and have this level of suspiciousness. They can believe that someone is going to hurt them. They may even identify someone or something. It wouldn't be uncommon for someone to say, I'm being watched, I'm being followed. The name of the organization or the agency is, there are people that are watching me right now. Don't you know that? Can't you see that? Because I can. So they are very, generally, if they're very suspicious or paranoid, they're very hypersensitive to things that are happening around them too. Hallucinatory behavior, that really means responding to hallucinations. So the person might be showing signs of what's called internal stimuli. So they might be talking to themselves, for example. They might sometimes yell or scream out loud. Their movements might be very bizarre. They might say to you or someone else that there are bugs that are crawling up their arms, and they then begin scratching and itching, but you don't see anything. There's no infestation of anything, but their experience at that moment is, and these are tactile hallucinations, that they are, in fact, they have bugs under their skin or they're crawling up their arms, etc. So this is just another of these different boxes that if someone were doing this brief psychiatric rating scale, they could check off this box, but then put a number in it as well. So you see the actual rating scale there is, for example, 0, it wasn't assessed at all, 2, the criteria or that particular box, if you will, say anxiety, the person was just not demonstrating any any level of anxiety that would appear abnormal, they would not check that box. Or rather, if they did, they would just put a number 1 there, meaning not present. And then all the way over to very severe. So this ultimately generates a score. And that's, of course, what the therapist or clinician in this case is going to help to use as a justification for what could lead to a diagnosis of schizophrenia or some of the other psychotic disorders that are discussed in the DSM-5. So let me show you one more. Just bear with me a moment. I'll try to find it here. Here it is. So this is, again, another rating scale, but this one, what's different about this is this could be completed by a loved one, for example, someone who knows someone who might be struggling with the symptoms of schizophrenia. And it can be completed by the clinician as well. But again, it isn't just the clinician's observation. In this case, it could also be the observations or the feedback from loved ones, family members, spouse, etc., friends. So again, there's a scoring procedure for this. It's a little, it's similar in that there is, again, this rating scale. Absent would be, of course, this score of 1 would signal it's not whatever it is the main category is in this case. And when you see the questions, it doesn't apply, or they're just not seeing it. But then you have more mild to moderate to severe, etc. So again, this ultimately generates a score. When you look at this too, I just want to go back here. So you're here looking for the presence of delusions. Are they present or not? And if they are, to what extent? What is the severity of them? The conceptual disorganization, again, we're talking about a brain disorder. It's a thought disorder. So to what extent is their thinking disorganized? Can they complete a task or not? Are they highly distractible? Can they participate in a conversation? So this is, again, a measure of someone's, the function of their, thought processes. Okay. Hallucinatory behavior, is it present or not? Level of excitement, this could be, again, more of how they're responding to things around them. Also, how is their behavior? Are some of their behavior, some of the things that they're doing, very bizarre? Or is it just the opposite, where they're actually not very responsive to anything at all? Are they almost catatonic? Is grandiosity present? And again, grandiosity is probably more closely related to presence of delusions, and that actually references that here, where you see moderate severity, clear-cut delusions concerning remarkable abilities, status, or power are expressed and influence attitude, but not behavior. So there's a difference there. The person is saying that they're Napoleon Bonaparte or Jesus Christ or Superman or Superwoman. They're saying that's who they are. The frightening part, and where it's then becomes more of a real safety issue, is if the person is saying, I am Superman or I am Superwoman, and by the way, I can fly, let me go demonstrate that. Unusual and probably very rare, but also could, for that person, be obviously very unsafe, very dangerous. So again, these are different categories. Again, we discussed this already: suspiciousness, persecution. What level of persecutory thoughts do they have? Do they feel or believe that they're being persecuted by others? Hostility. So this is not, it is again, a thought disorder we're talking about. It is an illness that affects your full range of your cognitive processes, how you process information. And unfortunately, for some, they could turn out to be more hostile toward themselves or other people. I will say again, this bumps up against the stigma that's associated with schizophrenia. Again, it is a relatively rare illness as compared to the broader range of mental illnesses that we've discussed in this course. However, even though it's statistically quite rare, there's a lot of misinformation out there about it. You'd actually think that it's much more common than it is. But also one of the misconceptions and myths that people have about schizophrenia, for example, is that folks with schizophrenia are very violent. It's actually not true at all. The instances where that has been some documented cases where someone diagnosed with or living with schizophrenia, undiagnosed, has hurt someone, does happen, and those are the things that typically make it into the newspaper. But on average, most people that have schizophrenia, whether in treatment or not, are generally not hostile toward others, are generally not a danger to anyone else. So just something to keep in mind. But this still is a measure. It can be present in some folks. And then again, now you see the negative scale. So before that, it was more the positive scale, if you will, the things that we see that in addition to what's more common. And now this negative scale is, again, looking at what's not present. So again, the absence of. So you could obviously move through this as well. Emotional withdrawal is a definite example of a negative symptom of schizophrenia. Interpersonal skills would be related to poor rapport, the inability for someone to really maintain social relationships with other people. Remember, in this course, we've talked about for each illness, I wanted you to think about what are the potential impacts that whatever this illness is, whether it's eating disorders or major depressive disorder or somatic symptom disorder, or in this case, schizophrenia, schizoaffective disorder, schizophreniform disorder, mild psychotic disorder, delusional disorder. What impact could these illnesses have on someone's social life and their ability to maintain relationships with loved ones and friends? Can they have them? Could they have relationships, friendships? And if they can, great. But if they're not able to do that, and if it's something they have, how do you help them to attain and maintain friendships? So again, but this again is part of the illness, is the person being more likely to want to self-advocate, self-isolate rather. Another thing I just want to say quickly, and this isn't related to poor rapport, but is actually the presence of motivation. So I think I may have used this example in one of the videos from chapter 13, but and from my own work with people with schizophrenia, it's not uncommon, especially for someone, say a young adult who's been recently diagnosed with schizophrenia or is at least showing the symptoms of it, if they're generally not driven to want to complete tasks. Example, they maybe are not completing maybe an application for, say, a driver's license, or they're not pursuing an application for college. And they seem to be really, I'm not using this word to say this is what I would call anyone that's showing this symptom. To others, they would appear lazy, and that would generally be used by someone that doesn't understand schizophrenia. But again, it takes away something that would normally be there. Most people are somewhat driven. We're driven to do things for any number of reasons and motivations, both internal or intrinsic or external or extrinsic. But in this case, the drive, if you will, is sometimes lacking. And for the folks that are not informed, they might perceive that the person is, quote, lazy or doesn't want to do anything. Well, it's actually a symptom of the illness. And that's what you're seeing, is that symptom playing out in front of you. So I hope this is helpful for you. I just want to tell you, too, that this is not to imply that all of the ranges of these symptoms are permanent, if you will. There's a wide range of treatments. Not all of them are pharmaceutical in nature, but many are. But you should understand that when these assessments are done, and the person, for example, let me just go back up to the top here. Actually, let me go down a little further. Oh, there you go. This is what I was referring to a moment ago, is more of that social withdrawal, the apathy, difficulty in abstract thinking. You could see here why someone would maybe have more difficulty pursuing college courses or succeed or completing college courses, because they really are having difficulty with their ability to really process information, to remember information. So that could impact their career goals. For example, it's not uncommon for some folks who may have started pursuing a college degree, if the symptoms become really bad or difficult to manage, they might not be able to remain in the courses until they then get treatment, get some help. What I wanted to say really, though, overall here again is, even though this is just one rating scale, it's a point in time. So the person may, hopefully, if this tool is being used to help to lead to diagnosis, well, diagnosis is not enough. It needs to lead to treatment. You know, the field of psychiatry, field of psychology, counseling is there to help to lead someone to improvement, to help them to experience fewer of these, what can be very devastating symptoms. So again, symptom relief, diagnosis is just the first step, and then what would follow should be treatment using the best practices that are available and accessing all of the available supports that are around that person at any time. So again, this type of assessment, for example, could be a point in time, and then we hopefully will see improvement in many of these measures over time if the person is in fact engaging in treatment and successfully, and they're getting the other supports that they need. So I hope this was helpful. It was a lot of information, but I just felt like it was a good opportunity to really show you more of just criteria. I wanted to also show you some of the tools that are out there that can be used to help to better determine if, for example, schizophrenia or a brief psychotic disorder or delusional disorder, etc., is present or not. So hope that was helpful.